As Amanda said, I'm Alexis Crabtree. I'm the public health physician for harm reduction substance use services at the BC Centre for Disease Control. And then I also work very part-time as a family doctor in inner city family medicine. I'll be speaking today on a forthcoming bulletin from BCCSU on adapting substance use care during extreme events. And you can expect the full bulletin to be posted soon on the BCCSU website and circulated within our networks. I'll start by extending my thanks to the BCCSU medical writing team for their work on the bulletin and on this presentation, and to colleagues at Health Emergency Management BC for their contributions as well. Go to the next slide, please. So our learning objectives today are describe potential disruptions to substance use care during extreme events, identify some of the risks associated with specific extreme events for people who use substances, and describe strategies to adapt standard care during extreme events. And then the next slide. I just want to start off here by acknowledging the presentation content today can be really tough to hear, particularly for anyone who has loved ones who are currently facing an extreme event, have yourselves or have others who have recently been on evacuations like those in Fort Nelson and others, or for people who are feeling apprehensive about the summer months ahead and feeling apprehension about patients they care for and care about, and others in their communities. So please take care of yourself however you need to during this presentation and afterwards, and check in on any colleagues that you think would benefit from a show of care. The first question is, this is a presentation on extreme events. How are we defining extreme events? Here I'm defining it as any local or global event which may present barriers to accessing necessary treatment, drugs, or harm reduction services by disrupting supply chains of unregulated or pharmaceutical drugs, blocking access pathways, or requiring people to evacuate their home communities or self-isolate. Some examples can include flooding, wildfires, extreme heat, or novel pandemics, which we hope we will never have again. BC's unfortunately had a number of extreme events in recent years, and we expect more to come. And some of the examples include forest fire evacuations, the heat dome in 2021, and the atmospheric river event, which caused flooding and road damage in 2021. The guidance here today is based on lessons that were learned from the document Risk Mitigation in the Context of Dual Emergencies, interim clinical guidance, commonly called the Risk Mitigation Guidance, and other COVID responses, as well as what we've learned from recent extreme events like wildfires and flooding. It should be noted that this guidance here is limited to the context of extreme events, offering information on standard care, flexibility, and alternative approaches to help people who use drugs stay safe during extreme events. Some of the alternative approaches discussed in this presentation and in the accompanying bulletin include prescribed alternatives to reduce the need for unregulated drugs and to manage withdrawal symptoms during extreme events. But this bulletin doesn't provide comprehensive guidance on provision of prescribed alternatives, or what we were formerly calling prescribed safer supply. That more comprehensive guidance on prescribed alternatives is available through the BCCSU Opioid Use Disorder Practice Update. And I think we can all acknowledge the harms from the unregulated drug supply are an emergency, and patients experiencing that particular emergency, which is many, deserve really comprehensive supports. Can go to the next slide. So people who use substances face urgent risks from disruptions and hazards associated with extreme events, layered on top of the drug poisoning public health emergency that was declared in 2016. People who access the healthcare system and people who don't can be at risk, and there's two major ways to highlight here. The first pathway is through withdrawal, and the second is drug poisoning. To speak first about withdrawal, different substances exhibit different presentations of withdrawal. Withdrawal from some substances can be incredibly uncomfortable, like stimulant withdrawal, and withdrawal from other substances can be life-threatening, for example, alcohol and benzodiazepines. Withdrawal can also trigger use of unregulated drugs, which itself can be life-threatening in the current context of our highly toxic drug supply. So it's important to remember that people can experience withdrawal from substances that they didn't even know they were using, such as withdrawal from benzodiazepines in someone who's been using opioids that are adulterated with benzodiazepines. Drug toxicity is a risk during extreme events for people who experience disruptions in care, like not being able to access OAT. But it's also a risk because of changes in the drug supply. Drugs travel in many of the same ways that other goods do. And when there's disruptions to transportation, it's likely there will be disruptions to the drug supply too. That increases the risk that people are going to be exposed to substances that are a different potency or have different contents than people expect, which increases the risk of drug poisoning. And I'll share an example here from the Yellowknife evacuations. I would encourage everybody to read the full story from Yellowknife Women's Services Society. They've generously shared what they learned on their website. They share that during the fires, people were evacuated to Alberta, and people experiencing homelessness were evacuated to a variety of places, including into general shelters in different parts across Calgary. And not all of them were able to access their prescription medication, including methadone, due to issues like the distance they were expected to travel to have a daily witnessed medication. At least 2 people died as a result. So the key message of this presentation and the accompanying bulletin is that adaptations to care are required during extreme events to ensure people can access life-saving treatment. Next slide. As with all substance use care, the following principles of care should be utilized during extreme events in order to provide responsive, respectful, collaborative, and person-centered care. So person-centered care includes reducing barriers and increasing flexibility, striving to provide care that respects the unique needs, values, and preferences of each person receiving care. People should be empowered to be experts in their own care. Social determinants of health, substance use disorders should be viewed within a larger societal framework, which is shaped by inequities, and clinicians should be addressing disparities by connecting individuals with relevant resources. That means clinicians need to know what those relevant resources are. And when we talk about extreme events, that means knowing the emergency supports that are available in your community so that you're prepared to connect clients to them. It's important to make a meaningful commitment to providing culturally safe care and practicing cultural humility, and to challenge racist structures in healthcare and recognize one's own role in oppressive systems. For trauma-informed and violence-informed practice, it's important to be familiar and incorporate principles in the care and clinical management of people with substance use disorders, with a goal of creating a safe and respectful environment that minimizes the potential for harm and traumatization. And I'm going to highlight one more here that I think is particularly, these are all important, but I think is really key when it comes to extreme events, which is harm reduction, including Indigenous harm reduction. We have our own goals, and it's important as clinicians to acknowledge where, we have expertise and things to offer our patients, but we also know that extreme events are a time where people are going to be under stress and be making decisions as best they can in the moment. We want to acknowledge and support any steps taken by people to improve their health and well-being, and respect their decision-making and their current goals during extreme events. Next slide. So throughout this presentation, we'll be discussing the standard of care and then alternative approaches to providing substance use care during an extreme event. Any slide with the green plus symbol will denote standard of care approaches, including evidence-based first-line care, and then provide some considerations for adding flexibility to support clients through extreme events. The orange puzzle symbol will denote information about alternative approaches for people at risk of drug poisoning or withdrawal whose safety requires some additional considerations. We owe it to patients to offer the standard of care. It's our best, most evidence-based approach to supporting health, but our goal in an extreme event is to keep people alive and to make sure they stay connected to care. So we need to be prepared to really listen to patients' needs in the moment and be ready to adapt care and deploy alternative approaches if needed. So now you can go to the next slide. Before talking about providing patients the standard of care during emergencies, I just want to talk about the standard of care before emergencies. All patients need planning, especially in communities where the likelihood of extreme events and issues from extreme events are high. And so it's important to think about care planning for patients, including um, emergency preparation alongside other types of care. I think of this as somewhat akin to, if people know the COPD action plan. So people who have lung disease, their action plans for if something goes wrong. We can also be supporting people to have action plans for their substance use care if there's a disruption, like they're not being able to make it to pharmacy or other types of disruptions to their care. As I said before, that means as clinicians knowing what resources are available and reviewing them with people in advance wherever possible. The standard of care during emergencies should be followed whenever possible before we start considering alternative approaches to extreme events. And some aspects of standard care include collaboratively developing a care plan with the individual, knowing that a goal during emergencies is to continue current prescribed medications to minimize disruptions in care and any harms that would come from abrupt discontinuation in medication. And identifying any alternative medications if their current medications are unavailable. The standard of care in an emergency also includes referring people to psychosocial services and other services to address their physical and social needs, including needs related to the social determinants of health. The standard of care involves ensuring continuity of care during the extreme event and after it's passed, based on a person's experience and goals. We know that even people who are evacuated will reach out to their primary care providers because that's where the relationships are, that's where the relationships are that they trust. And so there's an important role, even for people who aren't in communities, in maintaining that continuity of care. That means that there needs to be a plan for establishing regular monitoring and follow-up during and then after extreme events, including having a plan to return to the previous care plan or perhaps to adjust it based on the person having benefited from any adaptations that were made during the extreme event, that were ways that they were supported during the extreme event that have actually improved their health. You can consider virtual care appointments as part of this, and it's important to be monitoring and addressing barriers to in-person care. We consider that the standard of care includes sharing information about the First Nations Virtual Doctor of the Day program with Indigenous people so that they're aware of this resource for culturally appropriate care. All patients, as part of the standard of care, should have a discussion about harm reduction and safer use strategies and be provided with harm reduction supplies. And I'll speak later to some resources that are available during extreme events to support patients in accessing those supplies. And finally, it's always appropriate to consult. So consulting the 24/7 addiction medicine clinician support line or the rapid access to consultative expertise for addiction for expert support to adapt care plans where needed. Next slide. So person-centered care, an important value involves adapting as needed during local or global emergencies and disruptions to ensure patients can continue to access life-saving treatment without putting their health at risk or without facing unreasonable barriers. Some of the adaptations that can be considered that are still part of standard care include increasing doses or extending take-home doses. So if someone has been supplementing their OAT dose with unregulated drugs and can no longer access the unregulated supply, this may be a time where they need their OAT dose titrated to meet their tolerance. Providers can also extend access to take-home doses outside of what's recommended in standard care guidance to reduce any delays and barriers that might impact a person's ability to access and take medications as prescribed. This is particularly something to consider in rural and remote areas. As clinicians, we should be considering overall clinical and psychosocial stability, safety, and feasibility about extending take-home doses, but we should be quite prepared to support people knowing that the alternative, which is withdrawal and drug poisoning potentially, are serious events, and it's okay to adapt take-home doses during these events. Other adaptations that can be considered are delivering medications rather than having an expectation on patient transportation during extreme events. Reducing urine drug testing, if that's a part of regular practice for this patient, reducing clinic appointments and expectations that patients will make it to clinic during extreme events, offering virtual care, um, facilitating any transfer of medications to a new pharmacy, but really being sure that that new pharmacy can support the person. So not just giving patients a prescription to take to a new pharmacy, but really making sure that loop is closed and the new pharmacy is able to support that person as soon as they come in the door. Engaging other health providers to support medication management, so involving nursing and other colleagues, and peer navigators as well, who have so much knowledge of what people are going through and what kinds of supports will be most meaningful. Engaging families and friends where appropriate and at the client's discretion. And then working with local community supports, particularly in isolated rural or remote communities where these community supports are an essential part of care. In the next set of slides, we'll go over some standard care for and alternative approaches for some specific substances. So for opioids, if you go to the next slide, the standard of care is opioid agonist treatment. If the person is already on OAT, continue their prescription and develop a care plan for the duration of the extreme event, but become more flexible as needed. The standard is to offer OAT for all individuals who are not currently receiving OAT, but know that people will make decisions during the extreme event that are best for them. If people aren't interested in OAT, or they've previously tapered off, or they're not yet ready, you could consider providing PRN, buprenorphine naloxone, in a pill-in-pocket approach, so that people can have it with them. So if they are experiencing significant withdrawal or have cravings, they have it available to prevent a more dangerous situation from developing for them. They need a discussion of the risk of precipitated withdrawal and how to avoid it when any prescription of this sort is given. Next slide. Depending on the person's goals and substance use history, a variety of strategies may support them to reduce their need to access the unregulated drug supply and manage withdrawal symptoms. OAT dose can be increased. Longer periods of take-home doses can be given to reduce barriers. Prescribing short-acting opioids can help with titration if OAT initiation doses are insufficient for their tolerance. And then you can consider prescribed alternatives to unregulated opioids. Prescribed alternatives aren't an evidence-based treatment, but can be considered for people who these other approaches won't work for. Next slide. So when you consider prescribed alternatives to unregulated opioids, this is the prescribing guidance. So people can take 1 to 3 8-milligram oral hydromorphone tablets every hour as needed. That change you might note from the previous is because clinical experience and accounts of those with lived experience highlight the previous maximum dose for oral hydromorphine wasn't sufficient to address withdrawal and cravings. Therefore, there's no longer a maximum dose. It should be titrated to patient comfort instead. An alternative would be 80 to 240 milligrams of M-Esalon, sustained release oral morphine for use orally twice a day. In the context of extreme events, this is a short-term prescription. So this is a consideration that's provided during extreme events. There is a lot of considerations about this over the longer term that's outside the scope of this work today. Next slide. For stimulants, the standard care for stimulant use disorder is limited to evidence-based psychosocial treatments, CBT, and contingency management. So while we suggest offering if available to all individuals, we recognize that during extreme events, it's difficult and in many cases impossible to offer the standard care for stimulant use disorder. people who are using unregulated stimulants should all have a discussion of harm reduction and safer use strategies, including drug testing, if available, using a buddy system when using substances, and making sure people have harm reduction supplies. If a person is at risk of withdrawal because they can't access stimulants, then standard withdrawal management approaches should be used to treat common symptoms and keep the person safe. Next slide. You can consider prescribed alternative stimulants for people who are at risk of withdrawal or at risk of harms from accessing the unregulated supply, and who aren't interested or are unable to access standard treatments during an extreme event. There's no clear and consistent research evidence, but a 2020 meta-analysis suggests that prescribed stimulants may be effective for supporting some people to reduce or cease unregulated stimulant use. However, we'll acknowledge that clinical experience has found limited benefit. Given the limited evidence of potential harms and benefits associated with stimulant prescribing, careful assessment of risks and benefits should be done in every case, and case-based consultations can be done by contacting the 24/7 line or the RACE app. Next slide. For benzodiazepines, it's possible to have life-threatening withdrawal, so it needs to be very clear that that is a possibility and that it is very much an urgency if people are relying on benzodiazepines. It's important to distinguish between two types of dependence: long-term dependence to benzodiazepines themselves and inadvertent dependence to benzos in the opioid supply. Next slide. So the standard of care for benzodiazepines is withdrawal management with supportive care. The standard is a taper. A taper might not be appropriate during an extreme event, but should be offered because that's the standard of care. When considering inadvertent dependence, it can be really challenging to tell differences between benzodiazepine and opioid withdrawal, and so we recommend contacting the 24/7 line or the RACE app for consultation. Next slide. For alternative approaches can include continuing benzodiazepines for people who are dependent on benzodiazepines, though we recommend avoiding escalating doses during emergency events, recognizing these are stressful times for people, emergency events, and the dependence on benzodiazepines may be stronger than at other times. Next slide, please. The standard of care for alcohol is detailed in the BC Alcohol Use Disorder Guideline. That includes withdrawal management for alcohol. Outpatient management is suitable for people at low risk of severe withdrawal symptoms. Inpatient is better for people at high risk of severe withdrawal symptoms, but might not be available during all extreme events. You can consider offering withdrawal management as an outpatient treatment for people with a PAUSE score greater than or equal to 4. You can also consider temporary sobering centers, and people are encouraged to consult an addiction specialist for any further care there. For alternative approaches, next slide, you can consider managed alcohol programs formally or informally. Next slide. I'm going to skip over, in the interest of time, nicotine, and just say here that nicotine, this might not be the time when everyone will be interested in quitting. The standard of care is to support people to quit, and it's okay to use those same medications as a bridge for comfort during extreme events. For cannabis, again, the standard of care is to offer connection to psychosocial supports as best one can during extreme events. Next slide. I think I will skip ahead, thanks so much, to say we'll share resources and we can come back to them. during the discussion. And I'll highlight one provincial resource that people may be interested in accessing, which is through Health Emergency Management BC. There are 3 DAX Hope units, which support people who use substances during extreme events. And if you go to the next slide, these can be used to support people's harm reduction needs during emergencies and provide support to organizations, not just to individual clinicians. And next slide. There is some contact information for HEMBC staff should this be something that you would be considering in your areas. So I'll leave it there. Thank you so much.